Good afternoon, everybody. Welcome to this joint session. I'm Howard Kinnison from the academic section, and this is Joe Creswell from the section of oncology. The academic section holds a joint meeting every year, and this year we're having a joint session with oncology. We've got a very exciting program this afternoon. I think got some very experienced speakers on some very topical subjects. We've also got an innovative, interactive app to tell you about, and Joe's going to tell you about that before we start.
Yes, relatively speaking, I am the IT expert, which is a rather sad reflection. Anyway, basically, if you go to your app that you've all downloaded, and you click on this section, you can submit questions. If your questions are suitable, I will approve them, and then everybody else can see them, and then as an audience you can choose which are the most popular questions to ask, and we'll try, if we can, to pick up a bit on those. But this is something new, so please do bear with us. Thank you very much.
So to start then, we are very pleased to have Professor Mark Emerton from UCL, who's going to tell us the up-to-date, state-of-the-art role of MRI as a biomarker in localised prostate cancer. Thank you, Mark.
So thank you very much indeed, all of you. So this is a slightly different perspective. So Howard's asked us to look at the interrogate MRI, which a lot of us are coming to terms with and feel that it's going to change the way that we look at the disease, but look at it from a biomarker perspective. Biomarker is a word that was coined in about 1980 by the NIH. It refers to some indicator of a biological state or condition. You can see it as a kind of model, if you like, or a construct or an abstraction of reality that gives us some insight into the disease. Is it there? Has it changed? And is there something about the disease that predicts the future? And so those are the three elements that we can derive when we use the word biomarker. And we're going to really explore those in the next few slides. So here's a picture which will be familiar to many of you. This is an MRI. We've got the T2 and the T1 gadolinium that's closest to me. This is a man that had two sets of biopsies before he had this set of imaging, and both sets of biopsies were negative, and he was told that he was all clear. This is new information, and the reason it's different to the PSA and possibly the rectal exam is that the variable of location is given to us. And so with this new information, and previously we were blind to the variable of location, the needle was able to be directed in the midline, or just to the right of the midline, just above Denon-Velius fascia in the mid-gland. And one or two needles were deployed, which made the diagnosis of Gleason 3+4, 5 millimeters cancer core length. And so here we have images serving as a biomarker to give us location in order to make the diagnosis, and from that we can predict the future to some degree based on the Gleason score. But there's other information there as well. This lesion that you can see there is about 0.4 cc's in volume, so the maximum diameter is about 8 millimeters. It's triangular in shape. The T2 cross-sectional area is slightly different to the T1 cross-sectional area. The latter is showing increased perfusion, suggesting that the metabolic requirements of the tumour are certainly present and require that new and additional blood supply. The other thing we can derive from this is there is considerable capsular abutment. And if you look very carefully at the slightly raggedy images here on the gadolinium scan, you can see that there's a reasonable likelihood of at least microscopic capsular invasion, both directly from here, but also derived in terms of probability. So there's lots of new information that we can add to our model of prediction that was hitherto missing or was derived on obtaining the tissue. So there are a number of things that we would want a biomarker to do. One is detect, present or absent. Another one is to stage, and that's looking at the extent of the disease and the degree to which other, usually adjacent, organs are infiltrated. Another one might be a response to treatment. So you apply selective pressure on the tumour and see if it responds, and you would want to know and indeed predict the direction of that response. Another one is the evaluative, or the assessment. So you assess at time 0 and you assess at T1, and you want to be able to tell if there's a difference in either the volume of the tumour or indeed the nature of the tumour. And MRI to some degree is replacing previous trust biopsy in doing that. And the last one is the ability to predict the future based on the information you derive from your biomarker, whether it be from blood, from urine, or indeed radiological. And again, we're going to just look at these largely through the criteria that have to be met for an entity to merit the term biomarker. And usually when you're developing a biomarker, you go through the kind of proof of concept phase, and then a thorough experimental validation. So PSA went through this, PCA3, and other biomarkers are in the process of going through it. And we're looking at issues of validity, the degree to which the information purports to the truth. Construct validity, does it fit into our conceptual framework of disease? So as the disease gets worse, does PSA go upwards, for instance? Face validity, does the information we derive from the biomarker capture the totality of what this disease is? And criterion validity, in other words, the degree to which our biomarker concords with other things that we would normally associate with a disease or with progression. And that, with radiology, is normally a histological concordance. If reliability is compromised, validity is always compromised, so you want a test to be reliable when reapplied over stable disease. We want responsiveness, we want it to be robust, so it works as well in one place as well as another, or in one population compared to another. And prediction and value for money are the other criteria that we might want to consider. So if we just look at validity first, and I think we'll start with our construct and face validity, and just see the degree to which the information is giving us detailed information on the status. And if you look back maybe a few decades, this is probably all the information you might have had, whereas today you have the rich information that you can see on the lower right. And the construct here is that the rich, detailed, granular information is going to give us a greater ability to assess the disease, evaluate the disease, and hopefully predict the future. Cancers tend to have a reduction in the extracellular fluid. Part of that is a desmoplastic response, part of that is the increased cellularity, and MRI, through the diffusion aspect of it, allows us to assess that to at least some degree. And what it does is measure the movement of water and give us some insight into cellularity and desmoplasia. We also know that most tumours develop or exhibit an abnormal blood supply to meet the metabolic requirements of the tumour, and indeed MRI through the T1 gadolinium phase allows us to assess that component of the disease. So this is all fitting in with our theoretical framework of what we believe cancer to be. And indeed, many of these outputs, as well as looked at qualitatively, in other words, looking at the images and describing them, can be rendered into quantitative data, or whether that be an ADC value from the diffusion scan, or indeed curves that you can see here. And so this prostate refers to the one that you've just seen, and dynamically, some of you may have noticed that the abnormal signal was on the left here, and this is shown by this abnormal curve, where the blood supply comes in very quickly through shunting and then has an early washout compared with the normal tissue. And the differences between these curves, there's lots of work being done on it, and there are lots of derivatives that are being looked at to see if they have value in telling us something about the nature of the tumour and the propensity for that tumour to lean towards aggressivity. The other aspect, which is the face validity, really relates to whether the information concords with our current notion of disease. So in other words, when we see a prostate cut up at step section, does it look like the MRI? Or does the MRI indeed look like the pathology? And here you can see a T2 image in coronal. You see a little bit of an abnormality here. You can see it here in axial, a larger abnormality on the left, and a small kind of curvy linear abnormality on the right. Here we've got various derivatives of the diffusion scan showing the same anatomical abnormality but portrayed differently, giving us some insight into the cellularity of the area. And here is the T1 dynamic scan, so showing the blood supply, again, with those areas. All concordant, all giving us a richness of information which we're just starting to learn about in terms of whether or not this will predict response to treatment or indeed progression in the future. Part of the face validity is the ability to communicate this information, and there's been a lot of work done recently in trying to get radiologists and urologists to some degree to be able to interpret those images, assign numeric variables to them in a way that is reliable and robust. And this is ongoing now, and these are the numbers ascribed to the abnormalities here, which are portrayed here in a kind of cartoon version, and allow us to exchange this information in a way that is meaningful to both physicians and indeed to patients when you show them reports such as this. And this is now pretty much standard. I'm not saying it's done everywhere, but the consensus statements all ask for a pictorial representation of the disease, some scout images so that you can compare that and also show them to the patient, because I think they derive considerable value, and also some numerical values of probability. In other words, the degree to which clinically significant disease is either absent or present. The experimental validation of MRI has been ongoing. Most of this has been published in the very recent months or years. This is one that was published in January 2015, was in JAMA, and represents Peter Pinto's work at the NIH. And they were looking at an image-guided biopsy, in other words, testing the positive predictive value of MRI against a standard systematic biopsy. And what they showed was that the MRI-directed biopsy was by far the most accurate way of biopsying. It was more accurate than systematic alone, and also more accurate than systematic and targeted together, because of the reduction in the accuracy afforded by the random systematic biopsies. Just about the same time, in Rome, another 1,000 patients, 1,000 patients in that study. There were just under 1,200 patients in this study. And this is a randomized study exploring the utility of MRI up front in the diagnostic pathway compared to a standard of care. And in the hands of Panebianco and her colleagues, the standard of care resulted in a detection rate of around 40%, which is what you'd expect with a good trust biopsy in a population that were biopsy naive but selected to be at risk. If you were randomized to MRI, the detection rate was double, so 100% difference in detection rate, and exactly the same risk as this is a randomized study. And just to show the degree to which MRI dominates the diagnostic model, if your trust was negative in that randomization, so in other words, you were given the all clear, and your MRI was negative, and then you had a saturation biopsy, your residual cancer rate was around 30%. And if your trust was negative, all clear, sir, and your MRI was positive, your cancer detection rate was close to 90%. So a massive change in prior probabilities in patients who'd been told that they'd had the all clear. So the validation in the NIH study was against a systematic trust biopsy. In this study, it was largely, if you had a lesion, it was a directed biopsy, but if you didn't have a lesion, it was a 32-core saturation biopsy. And what was also interesting is that the negative predictive value, which was calculated in this study using that saturation biopsy, was 100%. So in other words, none of the men who had a negative MRI had any pattern 4 detected in their prostate when subjected to a 32-core saturation biopsy. This is the most recent study. This has appeared in European Urology, I think, last week, actually, and just looks at the degree to which MRI correlates with the things that matter. And these were tumors that MRI detected. This is work from UCLA. As tumor diameter increases, the likelihood of detecting it and capturing it also increases. As Gleason's score increases, the likelihood increases. The index tumor is very likely to be identified, as is a tumor if it's solitary. MRI is not perfect, no test is, but you can see that it is positively associated with both volume and grade which would be the key attributes that we would want of a biomarker. In terms of responsiveness, other imaging systems have RESIST criteria. We don't have any criteria for MRI at present in assessing whether or not a tumour has changed over time, though we're going to need it. We've subjected a cohort of men with visible lesions and randomized them to dutasteride versus placebo and watched them very closely over 6 months with sequential MRIs, which is allowing us to see both reliability of the imaging and also whether we can detect a response. If we look at a placebo-treated patient, we can see his lesion here on the right at baseline at 3 months and at 6 months, and can determine stability by 2 independent radiologists. This is another patient with a slightly more medial lesion, which is deemed to have increased in size slightly over 6 months. And here is a dutasteride-treated patient. He has a rather large lesion occupying most of the left peripheral zone of the gland, which was seen at baseline, stable at 3 months, and then reduced in size by around 50% at 6 months. And what this allows us to do, and this is the first time it's been done, is to identify responders from non-responders and progressors from non-progressors by just watching the tumour very carefully over a 6-month period. Here were 2 patients whose tumours doubled in size over a 6-month period. Here's a tumour who received placebo that actually reduced in size significantly. The blues received dutasteride, so there were some hyper-responders, some moderate responders, and some non-responders, as you'd expect with exposure to any selective pressure. So what we might have here is an ability to test empirically whether a patient is going to progress or not, rather than having to predict it, or a model in which we can define progressors versus non-progressors and actually test other biomarkers to see if they can give us some insight into the future. We might also be seeing a new form of systemic therapy for early disease, and I think this is one of the first studies ever which has had MRI as a primary outcome in early prostate cancer. So the notion of responsiveness is one that I think is going to increase significantly. Prediction is hard. I think it's early days yet. MRI hasn't been around long enough. Just to give you some insight into where this might be going, there's been quite a lot of work using CT scan and quantitative analysis of CT scans to try and predict the future of lung cancers. This is work done in Nijmegen. And this looks very much like a kind of genomic study. But what they're doing is looking at attributes of the imaging in CT scan and lung cancer in terms of intensity, shape, and texture. All these are patients. And when they're subjected over time and the outcomes, in other words, the status of dead or alive, is derived, they can see that, at least in some cases, imaging can help in discriminating between early survivors and non-survivors. But this is very early days. This is the discipline of radiomics, which will complement genomics and proteomics, I think, in the future. And finally, value for money. Again, early days. There are just 2 papers in the public domain and 1 that relates to the status as a biomarker. This is available for you. It's about an 82-page document on the NICE website, and it compared PCA3 and Phi against the standard of care, but interestingly, NICE decided to put MRI as part of the standard of care, which didn't please the makers of PCA3 and Phi very much. But suffice to say that in this analysis, the traditional biomarkers of PCA3 and Phi had no utility in the diagnostic pathway, at least when assessed by this group. And it's only when you really added MRI to the model that you had the reduction in unnecessary biopsies that went from about 900 to 400. And they concluded, and this will be my last slide, at a maximum acceptable incremental cost-effectiveness ratio of £40,000, all iterations suggested that clinical assessment and MRI dominated all other strategies. In other words, in this model, Phi and PCA3 had no contribution to make. Thank you very much.